So there's Michael Jordan, the elite basketball player. There's Michael B. Jordan, the elite actor. But in my humble opinion, they can't compare to our Michael B. Jordan, the elite hero of histiocytosis. And so, Dr. Jordan did both his med school and residency training in Dallas and then fellowship at Children's Hospital Colorado. He is the clinical director of the HLH Center of Excellence at Cincinnati Children's and plays a key role in the North American Consortium for Histiocytosis, or NACHO. And I heard a rumor you came up with that name, is that correct? You play a role? Might have, well, brilliant. Love it. On a side note, if you Google Michael Jordan Nacho like I did yesterday, you see a lot of AI-generated images of Michael Jordan, the basketball player, in a cowboy hat eating nachos, which I just found very amusing. But I'm really excited to have Dr. Jordan here and for his talk on HLH.
All right. Thank you, Arun. Okay, so how do I control this? Yeah.
Oh, here, right here.
Yeah.
So to advance, to go back.
Perfect. Awesome. Okay, so disclosures. I'll be talking about SOBI. This is the pointer. Yeah, have a look at that. Yeah, right. We're talking about SOBI drugs in particular. So, okay, so thank you very much for the invitation. Thank you, Amir, and always happy to talk about this topic. So. This is going to be a bit of a mix, right? So sort of practical stuff and a little bit of a science sort of grounding of the practical stuff. So we always have to start with pathophysiology. They're really practical, a bit about diagnosis, some updates in terms of treatment and transplantation. So when we think about disorders of, and actually this is a term that I did coin, actually, PIRDs. So primary immune regulatory disorders, right? So there's in the last 20 years, there have been hundreds of these things identified, genetic disorders of immune regulation, and some of them are what I would sort of classify as a Mendelian disorder of autoimmunity, like IPEX is sort of the prototype for that. Or you have these autoinflammatory disorders, such as like activating mutations in NLRC4 that turn on a completely different part of the immune system, right? And the main thing is they turn it on sort of inappropriately, and that's why it's an immune regulatory disorder. And then in contrast, there are these things that I think we should refer to them as disorders of T cell hyperactivation. And HLH, sort of the classic familial HLH, is the precise example here, but there's variations on that theme. Sort of messing up this neat kind of three category is there are increasing numbers of disorders of sort of cytokine signaling that can have some bit of autoimmunity and some bit of T cell hyperactivation, so it's a bit overlap. And of course, talking to hemonc groups, everybody, of course, knows these things that are not exactly inherited, right? But they're iatrogenics, right? When we try to re-engineer the immune system or turn it on, we are still sort of ham-fisted, and so we still lead to all sorts of sort of hyperactivation in CRS, which has a lot of overlap with the genetic source. But when thinking about history here, I'd like to point out that HLH is sort of the OG of this category, right? It's been identified since the middle of the last century, and you can see, in a variety of different contexts for quite a few decades now, in different names. Rheumatologists refer to it as MAS. Hemonc type people refer to it as HLH. But over the years, we've made real progress in terms of both identifying and then advancing treatment. Now, the core of HLH, when we think about it, because I'm going to talk about some of the complexities, really the core involves this pathway here. So abnormalities in a variety of genes, these genes you see circled here, in this one pathway, all about delivering perforin and granzyme into target cells as a way to kill them when they need to be eliminated by the immune system. When this is defective, then you get HLH. But of course, there are variations on this theme. So like I said, the majority of patients will fit into this sort of this perforin-dependent cytotoxicity is the etiology, but there are an increasing number of very specific genetic etiologies associated with either abnormalities of T cell signaling or inflammasome function, or in some cases even sort of macrophage sort of signaling that lead to the exact same syndrome. And they are, for the most part, I would say they're variations on the theme that they really are the same sort of disorder, but they have specific implications. Now, in terms of what we've learned experimentally, so this is, your typical control circuit, right? The same sort of thing that's controlling, the air conditioning in the room and a SpaceX rocket, right? So you have sort of feedback loops, and these are, of course, are ubiquitous in biology as well. And in the immune system, really what we realized starting probably almost 20 years ago is that really a key negative feedback loop in terms of this interface between the adaptive, the sort of the learning part of the immune system, and the innate, sort of the more primitive sensing part of the immune system, is really cytotoxic function. So this is how, when T cells get fired up, how they begin to put the brakes on before things get out of hand. And so when it doesn't work, you end up with something that looks like HLH. And so we know that experimentally, if you pick a whole bunch of different genetic lesions, the ones I showed you in the previous slide, but also ones that don't even affect humans in the same pathway that we know of yet, right? You end up getting something that looks like HLH sort of physiology. And when that happens, these T cells that are overreacting massively overproduce interferon gamma. And this interferon gamma sort of bathing macrophages leads to a lot of the features of HLH. We can treat this by either blocking the interferon or getting rid of the offending cells that are sort of out of control, that is primarily the T cells. And the other thing we established experimentally is that you only need a small fraction, like maybe 10% of normal T cells to sort of reassert this feedback loop. So that's super relevant to transplantation. So, and that leads to this sort of schema in terms of how we think in terms of the immune response. I pretty much kind of went over this. And just in terms of when the immune system turns on, one of the ways it turns off is using this perforin pathway. But this also points out multiple sort of nodes that are potentially for therapeutic intervention. So, but moving on from sort of a lot of our learnings from experimental models, I just want to point out that the features of the mouse model have really pretty much all been validated in human beings, and this is one of our validation sort of studies. And it's known that from giving live viruses to healthy volunteers, in humans, what does a T cell look like when it's very, very recently seen antigen? And it looks like this. So there's this sort of particular sort of flow cytometric profile that you can see with any sort of infection. And in the patients with HLH, we see it very, very prominently. And when you look at either normal children or, in this case, children with gram-negative bacterial sepsis, you really don't see this profile. And in fact, so even small amounts of these sort of really super recently activated T cells is enough to distinguish patients with sepsis, one severe inflammatory condition, from HLH. And I think that speaks to sort of the fundamental nature of HLH, that it really is sort of, death by T cell, you might say. And this is largely a CD8 phenomena. So it affects all T cells, but if you're looking at the T cells that normally exert cytotoxic function, it's the CD8 ones, and those are the ones they're much more affected by this. So this is a profile that, some people have advocated for using this as sort of you might say a poor man's HLH test, that every hospital has a flow lab, and if you can work up a panel to look at this sort of thing, you can have your own in-house assay. It's true. What we don't really know is we know it's not perfectly specific, because you see this, like I said, in healthy volunteers that you gave yellow fever vaccine to. So we know that with other infections that you'll see this, and it's been shown that with EBV infection, normal response to EBV can look a lot like this. So I think it's useful, but not widely utilized, I would say, for that purpose. So the other thing, too, that we understood quite quickly experimentally is interferon gamma is really central to the disease process. And in humans, you can measure interferon gamma, but it is actually not that useful, in my opinion, in terms of measuring it in the serum. It's very insensitive. What's actually far more sensitive are the chemokines that are just downstream of interferon. And so there's a family of chemokines exemplified by CXCL9, 10, and 11. And our clinical lab measures CXCL9 clinically these days for many, many samples. And what we showed a few years back is that CXCL9 is essentially always elevated if you compare to sort of healthy individuals. It's not exactly specific. You look at patients with sepsis, and they'll have elevations of CXCL9 as well, but not to the same extent. So we typically see 10 to 100 times above the upper limit of normal in our clinical assay. And other features like other cytokines, experimentally at least, can help you to distinguish HLH from things like sepsis. All right, so But what about from sort of understanding the pathophysiology and some of the key players? What about practical advice about diagnosing HLH? So I tell everybody I have 2 rules for diagnosing HLH, right? So number 1 is remember HLH is a process, right, which we can recognize using a unique pattern, and this unique pattern was based really originally entirely on expert opinion, but in fact, data have shown over the years, including a recent paper from the last year, where we sort of look at the features that experts have, felt is descriptive of children with HLH, and it actually is a pretty good set of criteria, right? And this sort of the process is what I just explained to you, right? Is that this sort of toxic kind of systemic activation of myeloid cell types driven by interferon gamma and T cells that are sort of spinning out of control. And rule number 2, and this is maybe a little bit pedantic, but this is a real problem we see clinically, is HLH is not the pattern itself, right? It's the process underlying that pattern. So sometimes people say, oh, they meet the criteria, so they must have HLH. But potentially forgetting the fact that things other than the immune system spinning out of control can give you all the diagnostic criteria, right? So, when we think of HLH, I'll show you in a second, it includes things like fever and splenomegaly. Well, there are other things can give you that, including malignant diagnoses that have nothing to do with sort of immune hyperactivation. So what are these criteria that we're talking about? Or what is this pattern? So these are the sort of the de facto diagnostic criteria for HLH. And as you can, most people are probably familiar with this if you're familiar with HLH. The thing that makes this criteria useful is that some of these features are things that you would see rarely in your typical child coming to the ER with fever who's kind of sick looking. So most children are not going to have splenomegaly, they're not going to have anemia, and so on and so forth. And some features, not only are they unusual, they're actually kind of paradoxical, right? So most of the time when the child presents with sort of fever in response to a viral infection, for instance, their platelet count will actually be elevated, right? So there's some things that are sort of backwards, you might say, from what you would expect. And so between this combination of sort of a kind of rare and or paradoxical features, it really makes this sort of diagnostic criteria, I think, useful in distinguishing HLH from a much less severe kind of normal, but potentially sort of strong kind of immune activation in a normal context. Now, HLH is complicated. It goes beyond just these sort of genetic cases, and so it's described in a variety of different contexts, as I alluded to in a prior slide. So we know that patients with SGIA in particular and other rheumatologic diagnoses will develop MAS, which is the rheumatologist speak for HLH. And it really is the same process, and there's lots of data to support that. It just has a slightly different look because the context is a bit different. But there are also these other cases, these patients that have cancer and are described as having HLH, or patients that may in fact have immune deficiency and have overwhelming infection and develop what's described as HLH. And so there's this, you might say, this fine line, and this is one that I think is still evolving. We don't quite understand that. In some cases, we'd say, yes, this patient has this sort of severe process of inappropriate, maladaptive immune activation. Other patients, yes, they meet the criteria, but they have something else going on. And so that case, you would say that's probably best thought of as a mimic, and it's not clear if it's a different process, then should you be treating it differently? So primary HLH is this the big circle there. Secondary HLH is kind of all these other things. And now I don't have on this diagram here infection HLH, because in fact infection can be a trigger regardless of whether or not you have a clear genetic etiology or one of these other sorts of contacts. So it's not really its own sort of category, and it's not by definition makes something secondary. It's more of a trigger. And then and to remind people, there are sort of these form-fruste variations of HLH, for instance, like sort of partially developed, so just brain inflammation, that can be tricky to diagnose, and that's all I'll say on that. So, and then finally, as I already alluded to, things that look like HLH but are not HLH, and there's ambiguity, even to now, about what is HLH in somebody who has malignancy. This is a sort of a practical algorithm. You can actually pull it down from the Cincinnati Children's HLH Center of Excellence website if you like, and just point out that it sort of highlights some of the specialized testing that can be useful for rapidly making a diagnosis and sort of rapidly sort of understanding the underlying etiologies potentially. So, all of which are done in our clinical lab there. So. Okay, but moving on to therapy. So just to orient everybody, HLH, the patients come in sort of on fire and they need something to sort of quench the fire, and that's where the role of sort of the chemoimmunotherapy that we use these days for HLH. But for most kids, if they have an underlying genetic cause, they need a transplant to ultimately have long-term correction of the process. And this is what standard therapy has looked like since approximately 1994, so that's a long time. I'll show you how things have evolved since then. And so, we recognize increasingly, because we have more options for treating HLH, can we do better? So, well, the first thing we want to think about is, can we minimize toxicity? And most of the toxicity really relates to the really, you would say, sort of time-intense dosing of etoposide, the twice-a-week dosing in the first couple of weeks. Once you space it out, it's usually not that much of a problem. Or, the relatively, these are not crazy doses of steroid, compared to treatments of leukemia, but there is significant steroid toxicity in this patient population. And in part because, this is a roadmap, but even though we're oncologists, you kind of have to act like rheumatologists when treating these patients. So you start high with the plan to work your way down, but inevitably you end up there's some bumps along the road. And so patients typically get, higher exposures than you see sort of per the original plan. Also, there remains significant mortality. This is long-term data, so things are probably a little better than this now. But this mortality, about half of it is pre-transplant and half is post. And some of this post-transplant mortality does seem to be excessive as well. It's not just sort of standard risk of transplantation. And most of the deaths leading up to transplant are relatively early, so the axis maybe isn't super clear, but I would point out that first section is the first 8 weeks after diagnosis. So really it's within the first week, 2, 3, 4 weeks after diagnosis that patients are dying. And the gray indicates these are patients dying with active HLH, and in most cases they're dying of the HLH itself. So in addition to toxicity, we also have really inadequate efficacy of the current sort of standard approaches. So one of the things that we undertook starting a couple of years ago or so is to try to understand there's been survival data, so such as this, published using these standard regimens, but there really hasn't been a lot of detailed response data. And so we began to look at our patients that we've treated over the years in much greater depth. And so we did a careful analysis using our patients, also patients from our friends in Israel and also in Arkansas. Dr. Mack was one of the authors on this publication, as well as colleagues there in Arkansas. And so we said, can we gather enough patients to look in really dense detail at the outcomes of these patients? And what we recognize right away, we still haven't published the response data per se. I keep trying to twist people's arms to finish that analysis, but what we noticed immediately was that you can pretty easily distinguish the patients that died versus those that survived using this sort of careful assessment of response data. And so we gathered up almost 90 patients that we could analyze in this sort of careful fashion. Until analyzing or looking at the causes of mortality exactly as expected, most patients died with, let's see if this fancy pointer works. Most patients died with active HLH, either with or without multi-organ failure, and potentially with EBV. We separated that out because there was enough of them. And the few remaining patients died of infection, in essence. So really, it was inadequate efficacy. And if you look at in panel B, if you look at, if the patients aren't doing well, then you tend to kind of sort of re-intensify the therapy or move on to some other therapy. It's usually referred to as salvage therapy. And in fact, the majority of patients that were treated for HLH, more than half of them ended up with some sort of re-intensification or salvage. I think also demonstrating that while standard of care therapy is useful, it's really more than half the time that's not what the patient actually gets because they need more or something different. And the time to escalation was more than about 4 weeks in most cases. So it took a while to sort of shift patterns. And on the bottom in C is just a variety of things that were given to patients. And I would just point out that most of these patients were in the pre-emapalumab era. There were a few that got emapalumab on the study, an early study, but mostly this is all pre-EMA. So a lot of things were tried, and not all of them were successful, obviously. But what we, and this is just pointing out what I already said, but what we could recognize quite readily is that, and this is looking at inflammatory markers, but if you look at soluble CD25, the patients that died in the sort of the open circles versus the ones that survived, when they walked in the door, they had the exact same level of soluble CD25, but the ones that survived, it rapidly responded to therapy. And the ones that died, they had this sort of, the soluble CD25 stayed high. And you can look at this either by the actual value itself or the relative change, which is what the second panel is, sort of the percent improvement. So as you go up, you're getting better. The same pattern applied to ferritin, that the patients that survived had a much more rapid response, much more convincing decrease, either by either measure, either way you look at it. And if we look at other markers, again, if you look at hematologic features, essentially the survivors and the non-survivors all look the exact same when they walked in the door. But as soon as you start treating them, then you can pretty quickly, recognize that there's some improvement. So in the case of like platelet count, the rise in platelets is much steeper in the patients that are survivors. Interestingly, ALC, which and by the way, platelets and hemoglobin are affected by transfusion, but ALC is not, right? That's the absolute lymphocyte count. What we noticed is that the patients that were non-survivors actually had a lot more lymphopenia, suggesting that they were experiencing more toxicity, perhaps, of the, or myelotoxicity from the etoposide. And the one marker that was different, clearly different, between survivors and non-survivors when they walked in the door was BUN. And this is probably multifactorial, ranging from renal dysfunction, multi-organ dysfunction, to GI bleeding. But clearly, if your kidneys are unwell, then you are definitely in a worse situation. And the same was true of creatinine. But when we sort of looked at essentially every parameter we could measure in these patients with dense data sets, and we did it a couple different ways, either looking at the raw data, because it's retrospective, not all data points are there, or even if you do a fancy imputation to try to look at what's potentially missing, we really had the same answer, and that is that the soluble CD25 is a key marker for understanding, are the patients responding, are they likely to survive with this current approach, and that if you begin to combine the things that are most striking in terms of poor features, then that really is quite powerful. And in fact, if you look at the patients, if the patient at 1 week after starting therapy, if they have 3 or more poor prognostic signs, all those patients died. Whereas approximately 90% of the ones that did not have these poor features, after only 1 week of therapy, they survived. So, and this is published, so I'll go kind of quickly here, but basically, within 1 week of starting therapy, you can pretty much decide, do I need to change course or not? Do I need to add another agent? Do I need to, you can't really re-intensify because you haven't de-intensified after 1 week, but do I need to really take a different tack? And so really, we think of this response adaptive therapy as very similar to sort of the revolution of managing things like ALL that occurred decades ago, that realizing that if you respond, if you go into remission with induction, that's a very different story than if you don't, right? So, okay, so moving on. So thinking about this framework of pathophysiology of HLH, there's a lot of places that we could potentially improve therapy. We know that if somebody comes in with something that's triggering the disease, you can always treat the trigger, whether that be typically an infection, what we're referring to, if it's treatable. Corticosteroids act very broadly, and they're kind of sort of like the spackle or the mortar that holds all therapies together. They're always involved in treatment. And we've known about things like anti-T-cell antibodies like alemtuzumab or Campath, ATG, for a long time. Etoposide has been utilized for decades. It mostly appears to act on the T-cell. But of course, what's become a reality in recent years is blocking interferon gamma. But increasingly, we have lots of options. We can block interferon gamma and other cytokine signaling. We can specifically block IL-6, IL-1, or IL-18, at least experimentally. But what is it that we're incorporating routinely into therapy? And that's this drug emapalumab. It was approved now over 5 years ago now by the FDA for essentially the second line treatment of HLH. So emapalumab, it's an anti-interferon gamma antibody, and the one thing that's peculiar about it is that in the presence of more cytokine, the antibody is cleared more rapidly. So because it allows for the cytokine to bind the receptor without signaling, but then that leads to internalization. So you have to have sort of a very dynamic half-life when there's a lot of target around. So the drug is not dosed like a typical monoclonal every few weeks, but it's actually dosed perhaps every few days is more typical in somebody that's highly inflamed. But we know from animal studies that this is interferon is a key target. And in the pivotal study that we published now, some years ago, it was clearly emapalumab with the steroids and largely without any other treatment was actually quite sufficient for a substantial fraction of patients. But as you can see, the survival is not perfect. And these patients, the responsiveness was actually quite, I would say, variable. And I'll touch on that more in a moment. But what we did know is that we were able to largely hit the target in terms of if you measure CXCL9 after a couple of weeks of therapy, it's pretty much normalized in most patients. In fact, really probably within a week, if you're hitting target, if you're dosing well, you can suppress the CXCL9. We also know that if the CXCL9 was suppressed by the time you got to the end of the therapy, which could have been weeks or months in many cases, the probability of responding is much better. That's what this graph is showing right here. Okay, so what are the downsides of blocking interferon gamma? Well, we actually know a fair bit about this because there are individuals born with defective receptors, or there's the occurrence of spontaneous autoantibodies against interferon gamma, which is probably more common than we realize. And what happens in most cases is these individuals have difficulties with, I'd say primarily mycobacterial infection is probably the most sort of serious sort of complication, so either tuberculosis or atypical mycobacteria, but also patients will develop shingles, they can have histoplasma, or maybe, I guess in West Texas you could have cocci as well. They're quite similar in terms of their need for interferon gamma for control. But salmonella, I would also add, at least hypothetically, though this is not really clear in the literature, but hypothetically we know that things like Ehrlichia and Toxoplasma and Leishmania also would be a real problem in somebody who can't respond to interferon gamma normally. So the main issue is dealing with these sort of kind of problematic infections, which most of our patients most of the time do not have. So I think it's a good thing, but it's something to be aware of and not lose track of. And so a few sort of editorial comments about how best to use emapalumab. So it is technically approved for essentially second-line use in the U.S., though in Cincinnati, we generally still use it second line, though we're trying to be a little more intentional and organized, and we've actually recently been discussing about how we might use it more upfront. Though I hear from other physicians elsewhere that there's lots of people that are using it kind of, as soon as they make a diagnosis, and we'll talk about the scenarios where that may be useful. The product label says start at 1 milligram per kilogram, but that's one thing I can say with confidence that I essentially never do. The only time I ever did it was when we ran the trial because the company said, we have to start at this level for reasons that still escape me. And so, we know that the patients oftentimes come in quite ill, and we know if we underdose that we are not effective. And so in almost every patient, I will start dosing at between 3 and 6, or at least maybe even 3 and 10 milligrams per kilogram. And if the dosing is typically twice a week, but if necessary, we've given it to patients every single day if they seem to have a really massive consumption. And this is where measuring things like CXCL9 is super valuable because it's a really dynamic, real-time, essentially a pharmacodynamic marker saying, yes, I have hit my target, or no, I haven't yet. So it's super useful. And as already mentioned, there's this list, a very specific list of sort of forbidden infections that you want to potentially consider, maybe screen for if it's relevant, but always keep in the back of your mind. So I actually had a patient recently with HLH that came to us who we said, it's a 2-month-old baby, totally classic familial HLH, straightforward, no evidence of infection. We said, well, just send a urine for histo because Cincinnati is histo central, just in case. And what actually came back was blastomycosis. And we said, that's false positive, never mind. So send it again. Came back positive again and again. Actually, this 2-month-old child had somehow, Still don't know how, had blastomycosis. He also happens to have biallelic perforin mutations, and he's currently going through transplantation. So we treated him with emapalumab, and we didn't worry about it. We treated him for the blasto at the same time. So strange things happen, and so it's important to be aware of when it matters if you're actually trying to block interferon gamma. So, and the other thing I'd point out, and this is where really has, I think, has had a big impact on our therapies, is that emapalumab, one of the great things about it, it is a completely different mechanism of action as all the other therapies that we traditionally use, whether that be etoposide, steroids, Campath or ATG, all these other drugs. So, and in fact, we rarely use emapalumab alone. If we feel like a patient needs it, it's usually in combination with other agents. And so the trick is trying to come up with what's the maximum efficacy with the minimum toxicity, I think, in most cases. Okay, but enough about emapalumab. I don't want to be a shill for one drug. It's also apparent, and this has been known for quite a few years, that all cytokines will signal through a related family of molecules, JAKs and STATs. Interferon gamma signals through JAK1 and JAK2, and we've had agents that block JAK1 and JAK2 for a long time. Ruxolitinib is probably the one that's been around the longest, but tofacitinib actually has been around about as long. And it's been known, and of course, but you can block multiple cytokines, which may be good or may be bad, depending on your clinical context. It's been known since at least 2016 that experimentally JAK inhibitors can be useful in the treatment of HLH. And by 2019, there were numerous case reports, and since then, there have been multiple clinical trials that are either completed, I think, only in China, but also ongoing in the US and Europe. And so there are some data, and so this is actually data, just one slide from one of the completed trials in China, where they were using ruxolitinib for the treatment of patients with HLH. So the patients showed relatively rapid benefit, and so there was a mixture. They did acknowledge that some patients actually had worsened cytopenias, and we've seen this, but it's not dramatic. And so we will on occasion utilize, just practically speaking, utilize JAK inhibitors in Cincinnati, but we find that we don't often need to. And when we do add them on, the amount of added benefit is not tremendous. And so when we look experimentally, we can actually see that the other JAK inhibitors are probably more promising. So this is an experimental JAK1 selective inhibitor that actually in our hands seems to be better than ruxolitinib in mice, I would comment. So, and so we don't really have much experience moving into other JAK inhibitors. We've used tofacitinib in quite a few children because it's approved to down to age 2 now, and it's utilized widely in the rheumatology world. It seems, again, sort of helpful, not like a critical agent. It's like an add-on, like a little bit of spackle, when you're trying to fix the holes in the wall. So, okay, so other targeted therapies. So, of course, we can block a lot of things. We can block IL-1 with things like anakinra or canakinumab, and this is widely used in the rheumatology world for patients with MAS. I would say that it probably has minimal benefit in children with classic FHL. You can add it on, little downside, but there's little benefit in my general experience. IL-6, we all know we can block it with things like tocilizumab in the context of CRS. And there hasn't been much sense that it's very helpful in HLH, though I think it could be a modest benefit. IL-18 for certain subsets of patients, so patients with inflammasomopathies like XIP deficiency, this appears to be super valuable. The only agents that allow you to block this are still experimental, though. So it's tadakinumab and MAS825, but hopefully those will get approved in the next few years. And so for those patients, that may really change things, and especially for the rheumatology community, I think it'll have a big impact. Let's see, I think I've already touched on all of this here. So, all right, and I'm going to sort of go quickly through here. So, the thing I would point out is that the way the oncologists use steroids and rheumatologists use steroids is rather different. So the rheumatologists, I assume nobody here's a rheumatologist. I don't want to, don't let me misquote things. Rheumatologists, when they say the word pulse, they're not talking about 2 mg per kg, right, or 10 per meter squared of decadron, right? They're talking about 30 milligrams per kilogram, right, a gram in an adult, right, per day for 3 days. And the rheumatologist experience, and I would say that I can vouch for this because we have some firsthand experience as well, is that if you do these sort of mega doses of steroids for 3 days, and then you quickly wean, you actually get relatively modest, very surprisingly little steroid side effects if you can wean quickly. And you can get a lot of benefit. And so these are, in the old days, they'd call them lympholytic doses of steroid, and I think that's largely what it's doing, is just, it's killing a lot of activated lymphocytes. But this is widely used. It turns out that it doesn't always work, even in MAS patients, right? And so what will probably be the next sort of approach in MAS patients is if they fail pulse steroids, is give them imipalimab. There's been one positive clinical trial, and there's a second one that's been completed already. That's sort of, I think it's before the FDA right now. So ATG is an approach that has been used historically. We actually tested it in a trial. I would say I don't particularly recommend it, but we do use related. So this is the trial I was referring to where we tried to combine it with etoposide. It wasn't particularly helpful, but what we do use in some patients is alemtuzumab or Campath, but I would say that that's mostly something that I would say that if I was not a marrow transplanter, I probably wouldn't use that approach necessarily because of the complications related to it. And there's the Chinese approach, which I think I'll skip because nobody uses that in the U.S. So why change from where we are? I think I've already alluded to the fact that there are shortcomings, right? But we know that if we could get rapid response, that would probably help spare some of these early deaths that we see. And we know that we have multiple drugs these days that can act in different ways that may be helpful, and no one has really tried to really quite combine them. We also have a real problem when patients show up with multi-organ failure, right? Like how are they going to clear their etoposide, right, for instance. So that's a special case, but it's a surprisingly common special case. And as I already alluded to, pulse dosing of steroids appears to sort of optimize some of this sort of benefit to the adverse effect sort of ratio, at least in MAS patients, we can say. The other thing I'd point out is that the real problem with etoposide is not that it's such a myelosuppressive drug per se, but is when you give it twice a week. That sort of schedule is really what drives the toxicity, at least in younger children. In adults, sort of our standard quote-unquote HLH dosing is fairly myelosuppressive, but it, once a week is really well tolerated if that's all you're giving. And so we really were thinking about how can we limit our toxicity, and so and how can we, of course, take advantage of the sort of what we understand about early response. So this is a schema. I would say this is nothing official, nothing we published, but what we're trying to move towards is patients that come in that are kind of on fire with HLH is in fact utilize pulse steroids, a dose of etoposide, and a dose of imipalimab at the very beginning, because that's really, when you need it. Now, this is oftentimes shaped by the fact that the patient may be in multi-organ failure. You can't really dose them normally with etoposide. You may have to 75% dose reduce in some cases. You may not be sure what the diagnosis is, so you may not want to give steroids or etoposide because you may obscure the diagnosis of the lymphoma you haven't quite biopsied. So you may want to just give imipalimab, for instance, right? So, but in the classic kind of patient, we really are thinking of, we need to start, the HLH94 template is you start high and you work your way down. Well, we want to start higher and work our way down faster, right? So do a very short kind of pulse steroid exposure, do just weekly etoposide because it's rarely going to be significantly toxic, and then also utilize imipalimab in addition. And then the latter stages of this sort of approach are kind of like what we do as you get into continuation of treatment of HLH right now. You can sort of these intermittent occasional doses of short little bursts of dexamethasone and occasional etoposide. So this is just a concept, and this is what we've done this we've tried to do this, I would say. Again, you have to be like a rheumatologist. You can't follow the roadmap precisely. We've tried this in a few patients, and it seems so far we're pleased with the general approach. So, all right. So now I'm going to move on to a special case here, and I think this is some interesting unpublished data. So when we think about infections in HLH, right, one of the main associations that most people are aware of is EBV. The EBV is a really super classic driver of HLH. But in reality, EBV HLH is at least two very different disorders. So one is where you have EBV is predominantly in the B cells, which is where it is with all normal infections, is it's predominantly in the B cells, right? But there are some patients that, despite the fact that its EBV is has a normal sort of course, they get super sick with this EBV in the B cells. But in other cases, and this is where this tends to be more associated with things like chronic active EBV, where there's sort of an abnormal course to the infection, the EBV, if you measure it, is more predominantly within actually T cells or NK cells. And so this is a very different scenario. So in the first situation, if somebody, so like I said, anybody who normally catches EBV, it's going to be predominantly the B cells. They'll get sick. They may have to take off some time from school, but they'll get over it, right? And they usually won't need anything at all. Maybe they might get a little bit of prednisone, but usually it's self-limited, right? Even though it's significant. But if somebody develops HLH in this sort of context, instead of being more self-limited, that tells you that while they don't always have a genetic susceptibility, there's a really high enrichment for these sorts of other diseases like XLP1, which is SH2 mutations in SH2D1A, or MAGT1, which is the X-Men syndrome. And these other all pretty rare disorders, but you would be suspicious if somebody, if that occurred, if they developed HLH after their EBV. And so if you additionally treat these patients with rituximab, in addition to perhaps etoposide and dexamethasone, you might even more quickly sort of help clear the EBV, or suppress the EBV, I should say, and actually the patients will generally benefit from that. And the main concern in these sort of underlying susceptibility syndromes is they may, in fact, develop, eventually might develop a B-cell lymphoma, right? So, and that's well described. But what's, I think, not so clear in the literature is that if the patients show up with HLH and you find that the EBV is not predominantly in the B cells, and by the way, our lab will do this, so you can send samples in. They'll do a sort for EBV PCR. They'll just simply do like a little magnetic separation of different lineages, and then just do PCRs on each of these. And so it's a clinical usable assay. And other places I know will do it, but I know it's not widely available. But if it's in the the T or NK cells, then it is usually, I'd say virtually always, not associated with any sort of monogenic sort of defect that we can identify. But instead, it's actually very highly associated with people of East Asian ancestry, oftentimes Hispanic and Native American ethnicity as well. So in fact, most HLH in China and Japan and Korea and Taiwan is in fact probably this sort right here. It's highly EBV associated. Rarely do they find an underlying genetic lesion, and most of the time it's going to be in T or NK cells. So, and this sort of HLH typically responds to etoposide and dexamethasone, but it actually usually relapses. And it may respond again, and then it will relapse even more quickly, and so on and so forth. And so, this sort of situation is that if you see this pattern occurring, right, then typically the relapses will occur more frequently. And in fact, what you're probably witnessing is sort of a lymphoma in evolution, we think. I mean, there are cases where these patients clearly did not have lymphoma, and after 3 courses, they do have lymphoma. And this is usually fatal. So if you see this sort of pattern, the patient has EBV, HLH, you treat them, everything's better, that's great, and then things come back, and you can actually send off an assay to determine, oh, it's actually in the T cells, then you know you're probably in trouble. And so these patients do not do well. The Japanese have sort of a standard approach that if they see it come back, they have sort of very specific criteria that I think it depends on your lab, so it's hard to say how they translate. But if the EBV is not suppressed far enough and it comes back enough, then they will quickly transition to multi-agent chemotherapy like CHOP. And then if the patients are not well suppressed with that, go to transplant. And that's probably a good approach. But the other approach, that I already mentioned, the other approach is actually one that was been reported starting a few years ago from a group in China. A group in Western China showed a series of patients in which they had either overt HLH or they had chronic active EBV, and this was a publication in Blood from 2020. And they treated them, instead of treating them with immunosuppression or corticosteroids, they actually gave them nivolumab. So they actually gave them anti-PD-1, right? So immunopotentiation, and they reported great results. That not everybody responded, but a substantial fraction, I forget the percent, over a third, actually cleared their EBV. And I corresponded with the authors, and they said, yeah, some patients seem to get worse, which was not so clear in the paper. Some patients got better, other patients it didn't really matter, and we couldn't tell any criteria why that was the case. There was a subsequent case report from a different center in China saying, yeah, here's an example where we tried it and the patient quickly died. They quickly got worse, and they had this sort of overwhelming pulmonary syndrome, which you could say could be a known adverse effect of anti-PD-1, but it was very acute. So it was probably more of an intensification of the HLHE kind of process, which led to failure and death. So this hasn't translated tremendously outside of China, but we recognize that this is probably a scenario that we could in fact could be doing this in some patients. So we were cautious at first thinking about this, and one of the things we did is that we decided that now that we have emapalumab available, if the patients are going to get worse, if we treat them with immunopotentiation as well as interferon blockade, that it may be a safer thing to do. We knew in the mice, if you give them anti-PD-1, they all drop dead super fast. So we knew that it could be a dangerous thing. But we've now treated, I think we're up to 10 patients with EBV HLH that we've given nivolumab to. Most of these patients had previously had etoposide and dexamethasone, had probably, I think, for the most part, responded and then recurred. And all of these patients had EBV predominantly in T or NK cells. And so in most cases, they were treated with concurrent emapalumab, just as a preventative, just in case. But these are patients that we did not give etoposide or other chemotherapeutics to. We tried to get their corticosteroids down to a very modest level, because you can imagine if you're giving them high doses of steroids and a drug like nivolumab, you're actually counteracting your own therapy. So they had to get well enough that we could get off of higher doses of steroids. There were notably 2 patients that didn't tolerate therapy, one that sort of very rapidly worsened, so we kind of abandoned that approach and gave high doses of steroids. And the other patient actually developed myocarditis, which is a known adverse effect of nivolumab. By chance or by reality, we're not sure which, neither of these 2 happened to be on emapalumab, so they're probably the only ones that weren't concurrently receiving it. But 7 patients experienced a response, and 5 of them have actually gotten a treatment course in nivolumab, completed it, and come off of the therapy. And 2 of them are still ongoing, and they're all surviving. And so these 5 patients that came to us with EBV HLH that was recurrent, refractory, persisting, some in cases actually meeting a definition of chronic active EBV, they cleared their EBV and with no further therapy, and they didn't have to go to transplant. So we're potentially excited about that there is, I think, a way to go. We still have no idea how to select these patients other than, whether or not they are basically have demonstrated that the EBV and the HLH is coming back after an initial attempt at therapy, and it's in the T or the NK cells. We have yet to treat anybody where it's predominantly in the B cells, and I think that's probably reflects the reality that there's not going to be many of those patients that probably would need this anyway, even though it could be effective for them as well. All right, so a word about BMT, and I think I got too many slides, sorry, yeah. So whenever somebody comes in with HLH, even if you know you're not going to transplant, you should still prepare for the possibility and try to control the disease process, but it doesn't have to be perfect, and in fact, good enough is probably the way we should think about things. It's when transplant is delayed that patients end up essentially not surviving. We do know that reduced intensity regimens are still associated with higher survival, and I'll show you more on that in a second. Oops, sorry. So this is just pointing out that there's a difference between EBV, HLH controlled and not controlled at the time of transplant. It does actually affect survival. And there's a big difference in our experience between reduced intensity regimens and the myeloablative or MAC regimens. Patients with HLH really just don't tolerate the more intensive therapy very well. The good outcomes were validated by the Ritchie study, which is one run by Carl Allen down in Houston a few years ago. But what they found, what we have shown as well, is that the patients survived, but they had a really difficult time with the durability of the graft. So intervention in this case is something like a second bone marrow transplant or other sorts of maneuvers like donor lymphocyte infusion to try to rescue the graft because the graft was not holding on very well. We know this is largely a phenomenon of younger children, which describes classic familial HLH, so under about a year is where it's really a problem. So we looked at our data. We recognized that, and I'm going to have to do this really fast to keep you guys on time here. We recognized that a lot of our patients that had been treated with emapalumab before transplant, for their HLH, seemed to be doing quite well, and we didn't see much mixed chimerism. So we did a retrospective analysis here, and we looked at all the patients we could get that had been treated pre-transplant with emapalumab, and then all the patients, and compared them to patients that had not been treated with emapalumab. And not surprisingly, the patients that got EMA were probably worse patients. They received a lot more therapies, and because they were getting it as a second-line therapy. In other words, they were the ones that were refractory. And in fact, they had more active HLH at the time of transplant. So it wasn't a cure-all, right? But we decided they were good enough they needed to get to transplant and not dawdle. And so when we looked at outcomes, what we saw was there was no difference in overall survival. But this was actually encouraging. You could see the trend was positive. The sample size is probably not even half as big as it needs to be to show any significant difference there. But these were sicker patients going into transplant, so we were encouraged by that. But where we really saw a difference was in the chimerism. So if the patients had been exposed to emapalumab pre-transplant, and there were a few patients that got it post-transplant, but for the most part we stopped when we got to the preparative regimen. But if they'd just been exposed to it, then the likelihood of them developing mixed chimerism, and particularly the really low mixed chimerism, was much, much lower. And this is based on whether you look at as low as they got or the most recent, which in some cases would be 5+ years post-transplant. So there was really quite a clear difference there. And you can look at this in an incidence curve here. This is the incidence of mixed chimerism, or in this case, what really matters is the incidence of severe mixed chimerism, right? So this is where it's low enough, below 25%, where you might really lose your graft, get HLH again, that it almost didn't occur in the patients that had been previously treated with emapalumab. So, and this is just another way to look at it in terms of intervention or high-risk sort of intervention-free survival. So, we think that, and this is breaking out by age group. So again, it really is beneficial for the really young children. It's probably beneficial for the older children, but there's not enough of a signal in the older children to really prove that. We'd need twice as many patients at least. So we really think this has had a major impact in terms of fixing one of the main problems with the reduced intensity regimens that we see for transplantation. So I think I've already touched on these points. We keep transplanting the kids a little bit younger and younger, and we're down to about 3 months now. We still use RIC for almost everybody, and I know that's quite variable by center, but I think it's pretty clear. And then one thing is a little bit of shameless advertising. So we have a registry for patients with HLH. So if you have any patients with HLH, you have any patients that you treated for HLH, even years ago, but we really are most interested in the most current ones, tell your patients about a registry. They can just Google HLH registry. They can Google into HLH, and it'll take them to our website. We have an e-consent sort of system on the website. They can consent themselves electronically. They don't have to, have anybody call them. We will be happy to call them if they'd like us to, but they have to reach out to us for that. But so I would say that we're really trying to gather that dense kind of detailed data. We can only gather that, I think, at other sites and through a registry mechanism. So please let your patients know.